The most common anesthetic failures occur in the molar region of the lower jaw. The thickness of the cortical bone limits the spread of the anesthetic, and, depending on the type and duration of the treatment planned, you may need to use either an inferior alveolar nerve block or an intraosseous technique. Above the mandibular foramen, on the medial face of the lower jaw, the groove of the mandibular neck is limited anteriorly by a soft crest which arises just above the mandibular lingula and reaches the neck of the condylar process. This groove is the ideal place to infuse the anesthetic solution without damaging the inferior alveolar bundle, as it does not connect with it. Medially, it is bordered by the sphenomandibular ligament, which extends from the mandibular lingula to the antilingula on the edges of the mandibular foramen, forming an anatomical channel with the surface of the bone. All the inferior alveolar nerve blocks use the same route to access the infratemporal fossa, only the penetration heights and axes differ. Ideally, the needle should travel between the medial pterygoid muscle and the deep temporal tendon. As the lingual nerve is diverted from its direct trajectory by the medial pterygoid muscle, it is closer to this muscle in this direction than to the temporal muscle, so it is preferable to locate the needle immediately inwards of the deep tendon of the temporal and sufficiently high in the intermuscular groove to avoid damaging the nerve trunk. Known as peak spine anesthesia in France, there are various techniques for anesthesia of the inferior alveolar nerve block, but some of them lack precision and risk damaging vessels or nerves and produce paresthesia of the lingual nerve or even the inferior alveolar nerve. In our practice, we continue to rely on the anatomical method described by Jorgensen and Hayden, which uses bone landmarks and provides, in our opinion, the best reproducibility while laterally diffusing around the nerve elements. The patient is asked to open his mouth wide, and then the mucous membrane is cleaned with a sterilized gauze so that the area can be clearly seen and palpated. Even though the mucous membrane landmarks vary from one patient to another, there are still anatomical markers which should be used so that you avoid any serious mistakes. However, they should be correlated with the bone landmarks, as these are by far the most reliable. Wedge the end of your thumb into the deepest part of the anterior edge of the lower jaw and assess the distance between the pterygomandibular ligament and the anterior edge. The point of penetration is usually a third of the way from the ligament and therefore outside this. By sliding the thumb medially and placing the base of the nail on the anterior edge, you will feel the reach of the deep tendon. Your injection point is 5 mm behind this, and you penetrate until you feel the tip of the needle touch the bone. The syringe should be orientated along the axis of the second premolar, or even the first molar, as it is always easier to correct the axis from the back to the front than the opposite way. The bevel of the needle must face the bone surface so that it slides better, and you can, if necessary, correct the trajectory by moving the needle slightly. When you feel the needle touch the bone, if necessary, you can inject a few drops of anesthetic so that you can reorient the syringe painlessly. Push the needle in deeper by sliding it along the bone, thus avoiding the lingual nerve and the inferior alveolar nerve. When the needle has penetrated 20 mm, you often feel a loss of contact. This means it is in the right position, so you do not need to adjust the penetration depth to 25 mm. Always aspirate before you inject the contents of the cartridge slowly over 2 minutes. A slow injection will save time later. Passive aspiration every 0.5 milliliters will also slow the speed of injection. Your equipment should let you aspirate using one hand, so you keep in contact with the anatomical landmarks for the next sequence. Straight afterwards, anesthetize the buccal nerve by using another syringe with a shorter needle. By withdrawing your thumb slightly, you will find the anterior edge. Inject 0.5 milliliters of the solution just here. This extra injection will significantly improve the effectiveness of an inferior alveolar block, as the buccal nerve may well be involved in the innervation of the lower molars. This sequence also gives more time for the previous anesthetic to impregnate the inferior alveolar nerve and stop the automatic dispersal of the solution, which occurs when the patient closes their mouth, as the masticator muscles act like windscreen wipers. If the solution just comes in contact with the nerve trunk, it will not have the required effect. It must remain there, which is why you need to inject slowly. Labiomental anesthesia does not guarantee pulp analgesia, whereas the lack of it is a sure sign of anesthesia failure. If there is still pain on testing the pulp, you will have to administer additional anesthetic, either using the Akinosi mandibular block technique to increase the nerve length in contact with the solution, or using an intraosseous technique. The Akinosi mandibular block technique is the technique of choice when you are faced with failure of the standard mandibular foramen block. And like the go-gates technique, it can be learned quite quickly. The only difficulty is seeing the needle impact point at the back of the maxillary mucobuccal fold, as the mouth has to be closed. To make this stage easier, you get the patient to execute a mandibular lateral excursion while still keeping interarcade contact. With the index finger, you feel for the anterior edge of the coronoid process. Then you line up the needle along the maxillary mucogingival line with the body of the syringe touching the maxillary zygomatic process. You can then penetrate medially to the bone coronoid process and thus the temporal muscle to a maximum depth of 20 mm painlessly and without resistance, but ensure that you remain in contact with and at all times tangent to the maxillary bone. Aspirate and then inject the contents of the cartridge slowly. This technique can be a bit disconcerting at first, as the tip of the needle never comes in contact with the mandibular bone. The intraosseous techniques are very popular at present, as they are limited to a small area. Used as the first-line measures for short-duration procedures, they do not produce the unpleasant effects that occur with mandibular blocks. In example, labiomental and lingual anesthesia. They are also a very effective weapon in our armory of supplementary anesthesia techniques, particularly when tissue inflammation alters the response threshold of the nociceptive fibers, thus requiring us to combine several techniques to overcome this failure. There has been a study of the histological responses to intraligament anesthesia showing healing of the desmodontal wound within a few days. However, this can only be expected if the periodontal region is healthy. Using an Anaject automatic electronic injector is more comfortable for both the patient and the dentist, as it does not require the firm pressure on the syringe piston that a mechanical syringe does. The dentist can concentrate completely on the point of impact and avoid blocking of the needle in the sulcus, as the solution is delivered automatically at a controlled speed. After injection of 2 to 4 tenths of millimeter of the solution anesthesia of the alveoli and pulp is rapidly obtained by diffusion of the anesthetic through the bone. However, in common with any intraosseous technique, the duration of action is limited as the spongy bone is well vasculated. Although there are a few clinical studies comparing the intraseptal, intraligament and transcortical anesthesia techniques, the intraligament technique is, without a doubt, the most common used. In comparison with the intraseptal, it does not run the risk of producing necrosis of the septum, it is simple to perform, and it does not produce the post-operative pain that can occur with the transcortical techniques. This document sets out the essential points for good local anesthesia practices. Aspirate systematically when giving an anesthetic at any site, not just when performing mandibular blocks. All authors recommend that the solution should always be injected slowly at 1 ml per minute, as this ensures the solution remains in contact with the nerve trunk, thus reducing pain and systemic effects. A slow injection will save time later. This is especially important for inferior alveolar block techniques, given the muscles and mobility of the lower jaw. Delivering the solution in the right place is only the first step. You must also ensure that it stays there. In the future, we will all be using automatic injectors as they give precise control over the speed of injection. Finally, do not forget that the solution should always contain a vasoconstrictor, adrenaline, at a concentration of 1/2000 in this case, no matter which area you are treating, unless there are any absolute contraindication. Consult the section on pharmacology for these contraindications. Founded in 1932, the pharmaceutical company Septodent soon rose to be a world leader in dental pharmaceuticals. Automation of the assembly line threatens the guaranteed high quality of Septodent anesthetics. The manufacturing process includes the final sterilization, which will guarantee that the dentist can have complete faith in the product. The production units have an annual capacity of 480 million cartridges, over half of all world production. The Saint-Maur unit, close to Paris, complies with the most stringent national and international standards. Europe, Japan, United States. A Septodent product has often been registered or passed in more than 100 countries worldwide. Each dentist can rest assured that, by using a Septodent product, they will be benefiting from the sum of health requirements worldwide. Our knowledge and ability, siliconization of the cartridge components perfected by our company, makes for steady, jolt-free delivery of the anesthetic throughout the injection procedure. Individual visual inspection guarantees that the product is of the very highest quality. Each cartridge is labeled so that there is clear product identification, adding that extra degree of security when using the product. The blister pack and carton makes the product especially suitable for dentistry use.